Thank you, Dr. Hefdonerson. Since neuroendocrine tumors and carcinomas differ from person to person, deciding the right treatment at the right time for the right patient is the goal. Now we hear again from Dr. Keutgen and Dr. Khan on sequencing therapies for liver metastases and advanced disease.
Good morning. I'm Dr. Xavier Keutgen. I'm a surgeon at the University of Chicago, and I'm also the director of the University of Chicago Neuroendocrine Tumor Program. Today, I will be talking to you about sequencing therapies for liver metastasis and for advanced disease. So, metastatic neuroendocrine tumors, as we all know, are quite common. In our clinic, a majority of patients that present with neuroendocrine tumors have metastatic disease, meaning disease that is spread outside of the vicinity of where the tumor started. One of the most common places for neuroendocrine tumors to metastasize is the liver. And if you look at this graph here, almost 50% of small intestinal and pancreatic neuroendocrine tumors present with liver metastases. And we know that liver metastases are also associated with diminished in survival, especially if liver metastases are bulky or large. So if there is a majority, greater than 50% of your liver that's replaced by metastases of neuroendocrine tumors, your survival is not as good as if you have less than 10%, as this graph shows. So, liver failure due to overwhelming liver tumor burden is a concern that we try to address with systemic and local regional therapies. Now, if you look at the NCCN guidelines, which are guidelines that clinicians use to guide their treatment recommendations, you can see here that if complete resection of the neuroendocrine tumor and the metastasis is possible, it's generally recommended to do so. However, often complete resection of all metastatic disease is not possible. And so there are a lot of local, regional, and systemic therapies that then can be used. This is an older version of the guidelines, but as you can see here, there definitely isn't one recommendation that says you should do this or that first. It's all an or. You can do this or this or this or this. And so treatment sequencing really is challenging. At the University of Chicago, we have our own algorithm for treatment of certain neuroendocrine tumors. For example, this is a treatment algorithm for our pancreatic neuroendocrine tumor patients. And without going in details here with you, you could already tell that there are quite a bit of arrows pointing in all kinds of different directions. So again, treatment sequencing is very important, but it can also be very confusing. What is treatment sequencing? So treatment sequencing, in my mind, means that you could combine therapy, right? So, for example, when do you use systemic therapy in combination with local regional therapies? It also means that you could treat according to certain biomarkers, meaning is there something that you can determine in the patient's tumor that would potentially tell you, well, you should do this therapy over this therapy. And treatment sequencing can also be related to patient preference because, of course, clinical expertise and trial data is important, but patient preference is as well. And sometimes we don't have any good data that says this is better over this. And so we discuss these options with our patients and we discuss the side effects as well. And we let our patients decide what they would like to do with us together. Why is it important to think about treatment sequencing? Because treatment sequencing, if you do it the right way, could improve therapeutic efficacy and patient outcome. It could also mean that you only treat patients when you actually need to. Very often, the journey of a neuroendocrine tumor patient is more like a marathon and not a sprint. So we don't treat you with all kinds of things right off the bat, but we try to treat you only when it's needed to treat you. And understanding which therapy goes first, which therapy goes second, or third or fourth may be very important in that journey. And then lastly, treatment sequencing also is meant to prevent cumulative toxicity and transformation of tumors. So if we know that we give a certain tumor one certain regimen followed by another one, and that the likelihood is that we will create enough damage to the cells that some could actually survive the damage and de-differentiate into a more aggressive clone, that wouldn't be a good outcome. So we got to pay attention to this. Also, for example, if we treat patients with different types of radiotherapies like PRRT and like Y90 radioactive beads to the liver, we got to pay attention that we don't over radiate the liver and that we don't cause any liver damage due to these different therapies. So choosing when to use what therapy and in what sequence is really important. But as I'll show you throughout this talk, there's a lot more that we need to learn about it. So treatment options for metastatic neuroendocrine tumors include systemic therapy like long-acting octreotide, which is first line, targeted therapy like everolimus, sunitinib, cabozantinib, chemotherapy like CAPTEM, and then PRRT. But there are also liver-directed therapies, so surgical resection or debulking, liver-directed therapy with our IR colleagues, and one of them, Dr. Khan, will talk to you a little bit at the end of this talk a little bit more about this, and then rarely liver transplant. And the sequencing of these therapies depend on a lot of factors, including tumor burden, tumor distribution, patient wishes, symptoms, comorbidities, and also access to therapies. Switching gears a little bit and going to systemic therapies, and an example of sequencing with systemic therapies, PRRT is something that many of you know about. It's a radioactive particle that's infused into the patient's vein and tracks down the cell surface on the tumor receptors and delivers a low-dose radiation to the tumor while limiting the toxicity to adjacent organs. And the NETR1 and NETR2 trial have shown that lutetium-177 dotatate, so PRRT, or Lutathera, is beneficial in patients with metastatic neuroendocrine tumors. But there are many questions that are unanswered when it comes to PRRT. For example, how does PRRT fit into the treatment algorithm of NETs? Should we use it early or should we use it late in the disease course? Should it be combined with other agents? And is PRRT better than other therapy in certain patients? So I'll give you a couple of examples of things that we think of as clinicians. For example, PRRT and tumor volume. So the question that we ask here is, can tumor volume reducing interventions such as surgery improve PRRT efficacy? So that's important from a sequencing perspective, because if it can, then perhaps patients should undergo surgery prior to undergoing PRRT therapy by reducing tumor volume. So there were a few initial hints in the NETR1 trial suggesting that patients that had tumors that were larger did not respond as well to PRRT than when the lesions were smaller in the liver. There's been some other trials out of Europe that showed that removing primary tumor mass would actually improve the survival of patients receiving PRRT. So we looked at this at the University of Chicago last year, and we included a little less than 90 patients, of which about 2/3 underwent surgery or surgical debulkings, and then 1/3 did not have any surgery. We used tumor volume measurements to measure tumor volume in our patients using dotatate. And when we compared the different surgical procedures that we did, we found some differences in the debulking versus no debulking part in terms of progression-free survival, as you can see on the right side. On the left side, there weren't really much differences when you resected only the primary tumor. So again, the more tumor volume you reduce by debulking, taking most of the tumor out, that actually had a beneficial improvement on patients that had debulking surgery versus those that didn't in terms of progression-free survival after they received PRRT. And we were able to determine a certain tumor volume in this particular paper, saying that if your tumor volume was less than 138.8 cubic milliliters, you would do significantly better after receiving PRRT than when it was larger. And not surprisingly, as you can see here, those that had no surgery in this group had a higher tumor burden on the right side in gray than those that had only the primary tumor removed. And finally, those that had surgical debulking had the lowest tumor volume, as you can see here in blue. Now, example number 2 of PRRT and sequencing and how we should think about it. So biomarkers. The question here is, can biomarkers predict which patient would most benefit from PRRT? And here again, this is some data coming from my lab that we published a few years ago, where we essentially showed that if your tumor, and usually pancreatic neuroendocrine tumors, had an MEN1 mutation, you would be more likely, or at least the cells and the mice that we used in the lab, were more likely to respond better to radiation. And when we looked at our clinical data set, so again, this is patients that either have MEN1 or DAX mutation and underwent PRRT, or those that did not have a MEN1 or DAX mutation and underwent PRRT. You can see here again that those that had a MEN1 or DAX mutation had a significantly improved progression-free survival here in blue, which confirmed the data that we saw in the laboratory. Their overall survival was also improved after PRRT. And when we compared it, for example, with CAPE-10, which is a chemotherapy regimen that we give to our patients with metastatic pancreatic neuroendocrine tumor patient, having a mutation in MEN1 or DAX did not make any difference in terms of progression-free survival. So it was really just for PRRT. Example number 3 would be combination strategies. So the question here would be, should PRRT be combined simultaneously or sequentially with other treatments to improve efficacy? And here again, my laboratory has determined that a certain drug that's used for breast cancer, it's not a chemotherapy regimen, but actually a hormone blocker, can radiosensitize neuroendocrine tumors. And here we have started a clinical trial that where we're enrolling patients with pancreatic neuroendocrine tumors at the University of Chicago. And this is a phase 1 trial where patients receive PRRT with fulvestrant, which is this hormone blocking drug. It's worth noticing also that the preclinical data from the laboratory that was used to generate this data here was funded by NETRF. So a little shout out here to NETRF for that. We have enrolled already 5 patients. We're planning to enroll a total of 6 for the first phase and then an additional 13. And again, combining fulvestrant, which is essentially a shot that you get in your arm, with Lutathera, perhaps, we'll have to see for those results to come back, could be an interesting strategy to improve how PRRT works. Now, there have been many combination trials that have either been explored or ongoing, combining PRRT with other therapies. You can see here, of course, there was the NETR1 and the NETR2 trial, but then also there have been trials looking at combining Lutathera with everolimus, CAPE-10, etc., etc. Most of these trials are phase 1 or phase 2 and have either not progressed or are still into phase 3 or are still into their early research days. There are additional ongoing trials combining Lutathera with, for example, PARP1 inhibitors, which are DNA sensitizers. So many different ways to think about how to combine PRRT with other therapies to make PRRT work better and to help us understand when we need to use it in the sequencing realm. Now, this is an intriguing case I wanted to present. So this is a metastatic PNET patient that underwent surgical debulking in 2018, had 4 cycles of PRRT in 2020, had bland embolization in 21 and 22, underwent CAPE-10 in 22, bland embo in 23 again, had some external beam radiation to the spine in 24, and underwent another 2 cycles of PRRT in 2024. Obviously, he went through all these different therapies because of tumor progression. This is what his dotatate looked like. As you can see, all the dark spots are tumor in the liver. You can see here some bigger lesions, including some pretty central lesions in the liver that were, quite frankly, pretty nasty. So after his 2 cycles of PRRT, however, he progressed within a few months again. And we then started him on cabozantinib, which is a new therapy that was approved by the Food and Drug Administration just recently. And his first scan after cabozantinib and after 6 cycles of PRRT showed a complete response. So that is a very intriguing case. So all the tumor completely disappeared. It is intriguing because it raises a lot of question when it comes to treatment sequencing, right? So why did this patient have a complete response on cabozantinib? If you look at the New England Journal of Medicine data that looked at the objective response rates, they were about 19% in cabozantinib for pancreatic neuroendocrine tumors that underwent a partial response. A vast majority either had stable disease or progressive disease. Now, partial response does combine tumor shrinkage with complete tumor disappearance. But looking back through the paper, I could not find any mentioning of one patient that had a complete response where all the tumor disappeared after cabozantinib. Another question is, did the previous PRRT induce changes within the tumor that perhaps primed the tumor to respond so well to PRRT? And therefore, should patient receive PRRT prior to cabozantinib? Obviously, that's a very provocative question, and I'm just throwing it out here. I'm not saying they should by any means, but it is definitely something that is really interesting and that needs to be studied because it comes really to the core of treatment sequencing. So how do we answer these questions? Well, we can't run a clinical trial with a million different combination strategies. This just doesn't work because it's too expensive to run clinical trials on all of these different combination strategies. And there are so many different drugs and so many different things that we can look at. And I just talked to you about PRRT and combining this, but you could say the same with CAPTEM or with long-acting octreotide or with all kinds of other therapies that are on the horizon right now. So we need to study these combination strategies in a preclinical setting using laboratory and translational research. We need to study the timing of the drug administration. What needs to go first? Again, that's treatment sequencing. We need to study tumor variables that affect how these treatments work. So these are all things that we can study in the lab, and that even though they're not always translatable in clinic, they at least give us a basic idea of, is it important to try to put a trial together to study this in our patients? And sampling tumors with surgery, for examples, or with biopsies is just one of multiple examples where we can get tumor specimens, study microenvironments and changes in the tumor and genes, etc., to really understand what we need to do and what is worth studying. So in conclusion, understanding and researching treatment sequencing is of utmost importance for patient outcome. Treatment sequencing is complex, multifaceted, and might need to be individualized according to patients and neuroendocrine tumor subtype. When it comes to liver metastases, a combination of tumor-reducing intervention using surgery and IR in combination with systemic therapies such as PRRT or CAPTEM is likely most efficacious for long-term tumor control. And after comparing treatment agents to placebo, newer studies are now studying combination strategies. So, like I mentioned before, there's technically an infinite amount of possibilities of what we can combine, but we need to study better with translational and basic research what combinations make sense and how to best define these different combinations to pursue them in clinic. And here, NETRF and basic research have a huge role to play because those funding mechanisms are the way for us to study these different treatment strategies. So I'd like to thank you for the opportunity to speak today to you about a very complex topic. I'm happy to take any questions later on in the Q&A session. If you'd like to email me directly, here's my email address. And thanks again for being part of this fantastic NETRF event today. Take care.
Hello, we'll be discussing liver-directed therapy for neuroendocrine tumor and neuroendocrine carcinoma. I have no disclosures. So at presentation, 46 to 90% of patients with neuroendocrine tumor may contain liver metastasis. This is associated with a poor prognosis, 5-year survival rate ranging from 0 to 40%. 80 to 90% of these liver metastases are inoperable, and systemic therapies may have a moderate effect on liver metastasis. And so liver-directed therapy is an option for these patients. This can be performed in a variety of methods. These can be broken down into ablation and embolization. The indications for liver-directed therapy are primary for liver-dominant or liver-only disease, used to treat symptoms from functional disease or to treat tumor bulk, and principally halting the progression of disease. You can see many of these indications refer to progression of disease, or if there are only 1 or 2 lesions in the liver to treat. Ablation can be further broken down into thermal and non-thermal. Thermal refers to microwave ablation, or basically burning the tumor with a needle. We usually perform these for 1 to 3 lesions in the liver that are less than 3 centimeters, performed under general anesthesia. We basically advance a needle from the skin through the liver into the target area that needs to be ablated, perform the ablation. The ablation itself usually takes about 10 minutes, and then we remove the needle. Patient wakes up. We usually observe them overnight in the hospital, and then they leave. Non-thermal refers to histotripsy, which we already had a brief talk on. Once again, this is a non-invasive, non-ionizing energy form of ablation that uses microbubbles to mechanically disrupt tissue. It can be used as a definitive treatment and also can be used in combination therapy. Metastatic neuroendocrine tumors are hypervascular. 80 to 90% of them get their blood supply from hepatic artery. The liver itself gets its blood supply from the portal vein. And so we're able to take advantage of this by treating through the hepatic artery and preserving liver tissue. The way we do this is we deliver embolics intraarterial to interrupt the blood supply to tumors. And embolization is within the NCCN guidelines for liver metastasis. The simplest form of embolization is bland embolization or transarterial embolization. This is when we deliver small microspheres or beads that see deep into the blood vessels supplying the tumor. These block the blood supply to the tumor and eventually help kill them off. We usually use these in liver-dominant disease. There is some caution in using these in people who have had biliary intervention or biliary stents. A step up from this is chemoembolization, and this is basically mixing those beads in with chemotherapy, the most common being doxorubicin. Now, what's better, bland embolization or chemoembolization? There have been a few studies, including the RETNET trial, evaluating the difference between these two, and so far there hasn't been a significant difference. The last is radioembolization, or basically introducing radioactive beads into the liver to treat these lesions. These are usually reserved for bulky liver disease with rapid progression. This can be used in the setting of prior biliary intervention or biliary stents. It does cause fibrosis within the liver in the treated area. This can make resection of those tumors afterwards a little difficult. This is the decision process we use at the University of Chicago. You can see that for patients who have liver tumor burden, greater than 25 to 50% is when we perform liver-directed therapy. The protocol itself, me as an IR will review the PET-CT or MRI imaging, as well as get a basic set of labs. During the procedure, we may administer some octreotide and or histamine blockers to avoid any carcinoid crisis, which refers to flushing or wheezing that can come from release of vasoactive peptides. And then post-procedure, we keep people overnight. This is usually to treat any symptoms of post-embolization syndrome, which refers to abdominal pain, nausea, low-grade fever that usually lasts 24 to 48 hours post-procedure. Most people leave the first day after the procedure. So here are a couple examples. Here we have a patient that we perform bland embolization on. I want to focus your attention on this tumor here in the right side of the liver that shows some activity on the PET-CT and their MRI. We see the lesion well defined there. Here's our angiogram, and we actually can localize the blood vessel going to that tumor. We do a CT intra-procedure to once again visualize the tumor and its hypervascularity. Afterwards, we mix those beads with some contrast, and here we can see staining of that tumor after embolization, telling us those beads went exactly where we wanted them to go. And we have our post-treatment imaging. Here we can see PET-CT where there's no longer activity of that tumor or lesion, and in 9 months you can see significant decrease in size of that lesion. Here's a second example, one that we performed histotripsy and bland embolization as a combination therapy. This is our pre-procedure imaging, multiple lesions in the liver. Once again, I showed these images from histotripsy prior, and after we performed the histotripsy, we went after the rest of these hypervascular lesions with bland embolization or those microspheres, and those 6-week post shows decrease in that size of the lesion that we did histotripsy on, as well as decreased size and enhancement of those lesions that were treated with bland embolization. One final example I have is a patient with a single lesion treated with microwave ablation. Here we have MRI and PET-CT showing a single lesion in the liver posteriorly. This is an intraoperative procedure where we have an ultrasound where we can see that lesion very well. Here's our microwave needle advance into the lesion. As we burn, there's some gas bubbles that form at the lesion, and our immediate post-procedure CT shows post-treatment changes in that area corresponding with where the lesion was prior. This is our post-procedure imaging. You can see 1 month post, there's some post-treatment changes 4 to 5 months post, evolution of those post-treatment changes, and 7 months post, that area where the lesion used to be now has no activity on the PET CT. And so these are a variety of ways to treat liver metastasis for neuroendocrine tumor and neuroendocrine carcinoma that we offer here at the University of Chicago.